Good morning, friends. Let's get going straight away to our advanced course on PVR, how to counter the scourge of PVR. Uh, uh, the faculty who are going to speak to us, they're really a stars faculty and who need no introduction. Dr. Lingam Gopal, he's a teacher to most of us, a mentor to most of us, and God to me. The others are extremely good friends and also my teachers. I'd request the audience that if you have any questions, please pass them on in writing if possible, so we can address them at the end. Some of the speakers might need to leave a little bit earlier, so they could perhaps be addressed if you've already written the questions and given to me. Since this is an advanced course, we are not going to go into all the basics of PVR like the classification, etc. PVR, we must remember, it starts when the retina breaks. There's a breakdown of the blood retinal barrier. The photoreceptors are ischemic. RPE cells are liberated under the retina and into the vitreous and over the retina. There is inflammation, multiple cells migrate over there, cells undergo transformation. Eventually, there's scar tissue formation, and slide is not advancing. Hello? Yep. No, you've gone. And laying down of scar tissue on the surface of the retina, under the retina, in the vitreous, particularly the vitreous base over the ciliary body. And this leads to complex configuration of retinal detachment. So a key step here is what is called EMT, or epithelial mesenchymal transition. So when the RPE cells are released, when the retina breaks open and the RPE cells move into the subretinal space, then through the break onto the vitreous and over the retinal surface. But as they move, they lose their polarity as seen over here. There are changes within the cell also occurring, and it's more like a rudderless ship, and it just settles where it goes and bangs. Now, if a critical number of these cells have settled at a given place or over various surfaces, and they undergo, because of all the chemicals involved, they undergo transformation into myofibroblasts. So they lay down scar tissue and they contract. So this results in a pull on the retina, resulting in reopening of breaks, or in, no, again the slide is not moving, sir. Reopening of breaks or creation of new breaks, etc. Within the retina, glial cells and Muller cells, they play an important role because photoreceptors are lost. Their connecting bipolar cells also undergo degeneration. So Muller cells, they expand to try to fill up the gap, but they also get transformed. And when a lot of them get transformed, it leads to intraretinal scarring, or what is typically called retinal shortening. A lot of chemicals are involved in all this. EMT actually is a physiological process. It's for wound healing. But when the wound healing goes haywire, like in a keloid, that's when PVR occurs. And to these various molecules involved, various attempts are being made about how to stop this process from going overboard, and thereby how to prevent PVR occurring. Risk factors, all of us know. Some of the new ones would be, not new, but relatively unknown ones would be cigarette smoking. One more reason why people need to give up tobacco and smoking. Gas injection while doing scleral buckling also tends to trigger PVR. because of fibrin secretion and inflammation, and genetic and immunological factors are involved as well, apart from so many of the known factors. So the maxims that I follow is remove as much of the vitreous as possible. Particularly, one needs to be meticulous in base dissection, relieve all the traction on the retina and ciliary body, leave a clean macula, wide ILM peeling at the posterior pole and resurgeries. PFCL, endodiathermy and laser should be used judiciously. Keep a wide armamentarium of microinstruments ready to deploy, and create retinotomies and retinectomies only if necessary. But when one decides to do a retinectomy, be very generous about the extent. Do not hesitate to buckle. Buckle is not outdated or old-moded, old-fashioned. Use appropriate tamponade for sufficient periods of time, minimize damage to the anterior segment, and good control of postoperative inflammation.